This session is standing in between the end of this forum and going back home, and I believe we're all looking forward to going back home. So the sooner we are all seated, the better for all. Now, while we're waiting for everybody to settle down, I'd like to call my panelists on stage so that we may begin this last session of the first ever Africa Health Forum. May I please call on stage Dr. Solange Hakiba, who is the Deputy Director General for the Rwanda Social Security Board in Rwanda. May I please welcome her with a warm round of applause, please. I'd also like to call on stage Dr. Timothy Evans, who's the Senior Director, Health, Nutrition and Population Global Practice with the World Bank. It is also my honor to call on stage Ms. Mary Amuyunzi Nyamongo, who is the Executive Director and co-founder of the Africa Institute for Health and Development, focusing in social anthropology. I'd also like to call on stage the Minister of Health and Social Welfare from Liberia, Honorable Dr. Bernice Dunn. And last but not least, we will be joined by Professor Sir Michael Mahmoud from the University College of London. He has just dashed off a bit, but he will join the panel when he comes back. Great. So it seems like we are ready to begin this last session, and just to ensure that I have consensus on this, I'm going to one more time ask for a resounding viva. So viva young people, viva! Viva Africa, viva! Viva WHO, viva! Great. I have consensus and your blessings to begin with this very last session of the Africa Health Forum. Now, we have two main objectives of having this sixth and last session. The first is to harness and pull together the critical issues from the previous sessions, and the second one is to propose a way forward towards guaranteeing people's healthy lives as well as well-being. Now, countries in the Africa region have made commendable strides in health during the era of the Millennium Development Goals. However, there remains unfinished business of the MDGs and the newly adopted Sustainable Development Goals, which call for even more efforts to ensure healthy lives and well-being for everyone in the continent. It will therefore be critical to improve the scope and mode of delivery of health services and also to address the existing inequities in order to have a meaningful impact on people's lives. The health sector interventions will need to be complemented by intersectoral action to effectively address the social, economic, environmental, and as well as other enabling regulatory frameworks to ensure that relevant gender and human rights, health, strong public-private partnerships, effective intersectoral action, adequate resource mobilization, allocation and use, and strong accountability are in place. At the end, it is important to identify ways that countries can optimize the multiplicity of stakeholders and the different resources, and to build a resilient health system that will sustainably address the health and well-being of the people without leaving anyone behind. Now, also, sub-Saharan Africa has a bulging population of the young people and increasingly elderly population. In the previous session, we had Dr. Julita talking about harnessing the demographic dividend through investments in young people. And this is why we decided to have this session. In the last 2 days, the first ever Africa Health Forum of the WHO Africa region, we have discussed very important areas regarding the road to universal coverage with focus on putting people first. These issues that we discussed, or various topics that were tackled through the diverse sessions, included health financing, getting value for money and taking financial responsibility for our own health. We discussed e-health, global health security, health research, innovation and data for sustainable development, engaging Africa's youth to achieve universal health coverage, The contribution of private sector for universal health coverage. We did have a session that looked at old enemies such as HIV, TB, as well as malaria, as well as new and emerging threats, and the role of adolescent health in achieving sustainable development goals. Experiences were shared, situations reviewed, challenges and opportunities identified, and ideas generated on these challenges. As we come to the end of the forum, we need to take stock of our 2-day deliberations and distill out the key opportunities and make suggestions, concrete suggestions on how to move forward on the road to universal health coverage in the region. In this vein, the panelists have been derived from the previous 5 sessions, and they have participated in the past 2 days. In paving the way for the way forward, we should learn from our history in order to inform the future. And I remember yesterday's moderator said that as Africans, we should be bold in confronting our challenges in order for us to be able to overcome them. As we look forward to new initiatives, let us remember to preserve and build on what has already worked in the past. And by nature of the Sustainable Development Goal number 3 that says, ensure healthy lives and promote well-being for all at all ages, the efforts will require strong health systems that can provide health coverage to all, but more so to call for beyond the health sector for health and more so for well-being. We were reminded yesterday that we are left with a couple of days, well, a good number of days before realizing the Sustainable Development Goals. To be precise, we're left with 5,000 days before we have to achieve the Sustainable Development Goals targets. Therefore, each day that passes matters. We need to harness the commitment of the governments, the partners, stakeholders, including private sector and young people, and move from just talking and now actually walking the talk. There is an African proverb. I'm sure you've noticed that I love African proverbs because I'm a Pan-Africanist. But there is an African proverb that says, if you want to go fast, go alone, but if you want to go far, go together. And we try to walk the talk. Let us remember the commitments that we've made globally, regionally, and nationally, and look for mechanisms to pursue and honor them. This is why we've put together this panel. And they're going to discuss the feasible options for the issues that I've highlighted above in the context of Africa's efforts to put people first in the pursuit of universal health coverage and achieving the Sustainable Development Goals. So to get the ball rolling, I'm going to start with Mary Amuyunzu Nyamongo. Now, we know that almost all countries through their constitutions have recognized health as a basic human right afforded to every citizen. To what extent have the countries risen to the occasion to meet this provision, and what do you suggest could be done more in terms of availability, accessibility, and even utilization of quality health care services in country? Nyamuza, you have 5 minutes.
Thank you, Gigi. Before I start, when you greeted us, you said, "Viva young people." And I almost felt like saying, "Viva old people." Do we have any old people here? Actually, just between yesterday and today, and the discussion on adolescents, the discussion on youth, the discussion on women and children, and all the photographs around the room, just brings to bear the fact that we really need to approach UHC from a life cycle approach. What are we doing with children? What are we doing with adolescents? What are we doing with the youth? What are we doing with adults? And most importantly, what are we doing with the older persons? Because although nobody has really addressed the issues around older persons, that's when NCDs become a major problem to ourselves and to our countries and to our communities. So basically, from the beginning, let's try and look at it as a life cycle issue. Let's look at the needs for the different stages in life, and let's target those needs in a coherent manner. I'll start by looking at referencing some of the key messages that came through. Dr. Gitai of AMREF said, "The day we see the government taken to court by a citizen on account of right to health is when we shall know that health is actually a right." that we have this in our constitutions, but we do not reference the constitutions when it comes to health provision. Someone else said we should stop focusing on treating specific illnesses and instead adopt a more holistic approach to maintaining the health of individuals and communities. That people are not diseases. People are community members. And as we approach UHC, we should be holistic in the way we look at a person. In the NCD, we say, when I sit in front of you, I could be having malaria. I'm a woman, I'm a mother, I have reproductive needs, I have other needs around me, I may be diabetic, I may have hypertension, I may be having malaria. So when I sit in front of a doctor, I'm just not a malaria patient. I may have other issues that looking at me holistically would provide more dividends. And then today, Sir Michael, who's just walking in, talked about changing the definition of PPP to Partnership for Public Purpose. So as we move the agenda of UHC forward, we really need to ask ourselves, the partnerships we are getting into, the partnerships we are strengthening, what is the purpose of all we are doing? Is it for public good? Is it for individual gain? And as we do this, as we redefine, as we look at the life cycle approach, and as we put people at the center of what we are doing, we need to think through what their needs are at the different levels. Just being here in Rwanda and being here in Kigali, for instance, and just going back to the session we've had with the First Lady, Her Excellency, joining us, shows that political leadership and clear strategic vision for our countries is key to UHC. The fact that the president in this country goes for community service, takes leadership, has the people at his heart in the decisions and in the actions that are taken in this country, calls for clear political leadership at the country level. And as we live here, and maybe through WHO Afro, we need to ask our leaders, what do they stand for? What drives them? We were told what challenges him is his experience. What challenges all the ministers and the principal secretaries, and I'm happy to be here with our principal secretary from Kenya, what drives them? What drives all of us sitting in this room as we look at the issue of UHC? Some of us are children of poverty. Has that driven us to be where we are? And what can we do with what we have? I will also go back to the issue of primary health care. I am a social scientist, I'm an anthropologist. And the discussion we've had is how do we build from the individual, the household, community to the frontline health facilities? How are we strengthening those structures to ensure that people understand they have a role to play in their own health? That it's not you giving them health, it's them taking action and making movement towards their own health and actualizing that desire to be healthy. And that is a key message. And sometimes we forget that in UHC, the individuals are important. The Minister for Health for Rwanda talked about the communities and the communities taking initiative to have community health insurance, that the communities themselves, and they remind each other, you haven't registered, you will have a problem. And so ensuring that we acknowledge communities have resources, communities have ideas, communities have innovation that we can build on as we expand on UHC is something that we need to build on. And finally, before Gigi calls me out, targeting the poor and marginalized and leaving no one behind. I'll go back to the issue of research. Who are we leaving behind? Where are they behind? And what strategies can we use to bring them at par at where they can become members of the community as we desire them to be? We have lessons to learn. Somebody talked about social protection. And I want to emphasize the fact that we really do need to move outside the health sector. I know in Kenya we are experimenting, we are piloting using the social cash transfer system to enroll people in health insurance. The same has been tried in Ghana. Can we learn from that? can we expand on that so that the poor are not left behind, but using existing structures to ensure that they get access to this? And finally, the issue about strengthening health security was mentioned, and ensuring that we are ready and able to respond to emergencies. I'm sure my colleagues will talk about the rest, but I thought those were important for us to reiterate. Thank you very much.
Thank you very much for that. Please do feel free to give a round of applause. So a little bit later on, we are going to expand more on what you're talking about, the need to have community engagement and ownership, but also how often, if we were to measure the progress of healthcare security and delivery by the legislation and the human rights treaties that our countries have signed to, would probably assume that we don't have any healthcare problems in our own countries, but there's still a huge gap in delivery and in ensuring that the services that are given are of good quality. Now, I'd like to welcome once more Sir Michael for joining us, and I'd like to say your timing is quite perfect because you are the next speaker. Now, I'd like for you to speak about the lessons that we can draw from the past efforts of the PAC as well as the MDGs. And now we are transitioning into SDG era, and with specific focus on SDG 3. What can we learn from what has been done in the past in Africa, but also elsewhere in the world? And how can we place health needs in Africa in the context of socio-economic trends that are emerging? Sir Michael, you have 5 minutes. Wow. Excellent time management, just under 5 minutes. Thank you very much for your very optimistic and insightful intervention. And I must say, you are quite at liberty to use any word, no matter how strong it is. Just remember, we're not responsible for what happens thereafter. So you have the liberty, you're just not protected. You talked a lot about the need to invest beyond health, and I think that's something very important. And I remember during the Global Strategy on Women's, Children's, and Adolescent Health consultation, there was a lot of talk around how we need to recognize that when we talk about investing in somebody's well-being, there are other sectors that are also intertwined to the overall well-being. So it should move beyond health sector, but into other cross-cutting sectors as well. And thank you for bringing in that component on the environment as well. Now, I'm going to be moving to the Minister of Health from Liberia. Speaking from the perspective of a member state, what are the best mechanisms that can be put in place to harness intersectoral action in addressing social determinants of health in complementarity to the health sector efforts? Honorable Bernice Dunn, you have 5 minutes.
And the worms destroyed crops and infected the drinking water source. The communities elected the health sector. The Minister of Health passed on the information to the Agriculture Minister on grounds that he is responsible for human beings and not responsible for crops and creatures that destroy crops. The Minister of Agriculture requested for support from the Finance Ministry, but that delayed, maybe because the Finance Ministry did not see it as an emergency because it was not the health sector that was asking. 2 weeks later, the president went to identify with the community, and she got a very bad and negative feedback. No sector had been in the community to help them. So she was annoyed with the Minister of Health. She refused to accept that this was not my job. The Minister of Health just then got in contact with his colleague, the Minister of Agriculture. And he found out that the Minister of Agriculture did not have the resources to intervene. So the Ministry of Health transferred some funds to the Ministry of Agriculture, and then they intervened, and that solved the problem. Now, the decision makers and the policy makers do not see those things that affect us, the social determinants, as a health issue. So the social determinants are mostly responsible for inequities in health. They are things that are related to the way where we were born, where we grew up, how we live, how we work, and age. It requires political will and leadership. Sometimes, we say they will, but it needs to go beyond just the proclamation into action. And many times it's difficult to bring our colleagues from other sectors together because we are all focused on our individual responsibilities. But there's a platform. We all work with partners, civil society organizations. But if you look in country, almost every ministry, every sector have another organization, especially within the UN, that work closely with them. For example, the Ministry of Health works with WHO very closely and UNFPA closely. Finance Ministry works with the well-being very closely, and agriculture works with FAO closely. So sometimes when it is difficult to bring us together, maybe a strategy is to get through those UN agencies and they bring us together, because sometimes if we start, you don't get the right people at the table. Now, there's a need for a policy framework and strategies for us to to be able to work together in a multi-sectoral collaboration. And many times, we all know that government doesn't pay. And so it is difficult to attract skilled technicians that can help you to put some of these strategies together. But there are partners in country that can actually help you and work with you. Many times, also with partners, we like to put our rubber stamp on things. So everybody wants visibility. But it is also good to just work with the government, let the government drive, and you support, and you will be able to get what you want. Yesterday, I gave an example of how the IMS system was established during the Ebola outbreak. We had a sector that was had been coordinating the health sector issues before the outbreak. During the outbreak, it was partners that helped us to put in, though the government cheered, to put in the IMS system, to put in the EOC system, and all the way down to surveillance systems within the country. It's the government that was seen as the face, but we all work together. It is necessary that we decentralize the services and the systems, because sometimes our actions remain at the top. But those things that affect the social determinants are actually imminent in the communities. So when you decentralize, it provides the opportunity for local governance structures to directly address their health issues and the inequity issues within their context. The framework and policy should also provide the means for mutual accountability and responsibility so that we can hold one another accountable. And it will require a whole of society and intersectoral approach. So everybody have a role to play. And from the word go in designing those things, all the stakeholders should be on board. So we'll all see it as ours, and we contribute towards the success of its implementation. Thank you.
Thank you very much for that, Honorable Minister. And I think you're highlighting key issues in addressing health issues in Africa, just development work in Africa, and many meetings that you could attend. You always hear the challenges of coordination and lack of collaboration at different levels of partners, stakeholders, and how they relate or work with the government and other community stakeholders. I remember last year during the Africa Regional Consultation for the AHA framework, the Accelerated Actions for Health of Adolescents framework, WHO convened a consultation, and I think it was really good that they called the Ministry of Health representatives as well as Ministry of Education, because even for us as civil society organizations, we tend to struggle when we do adolescent health programming interventions, and we have to work with the different actors there. So I think it's very important that you highlighted the importance for proper coordination, collaboration, and working with the agencies, the stakeholders, and with the leadership of the government. Now I'm going to move to Timothy Evans. Yesterday, you profoundly noted that 2/3 of the economic growth is driven by human capital. And as such, it's very important for member states to invest in the education and health of the people. Now, how can countries in Africa ensure sustained health gains? And by the way, Timothy, it's not a coincidence that you're sitting next to me and we have this stopwatch so that we can monitor the time together. So you have 5 minutes, starting now.
Thanks. I have a little difficulty hearing, so thank you for providing me with 25 minutes. I will try and keep to time. So first, I'm talking about some action verbs because I think that's what we need to take. First thing is to agitate as key to sustainability. It's about civil society recognizing that 20,000 people per day are impoverished due to payments for healthcare in Africa. 20,000 people every day. That's great material for civil society. But we also have to keep ministers of finance accountable to recognize that this is an investment, a critical investment. And I was just with the Ministry of Finance over lunch, because what we find with ministers of finance, with all due respect, is they suffer from short-term memory deficit, meaning they're always being retailed for priorities. And so we in the health sector have to remind them day in, day out of that very attractive return on investment. And then we need to monitor progress with time-bound targets. So WHO and the World Bank will release an update on where we are in pursuit of UHC by 2030 on December 12th, UHC Day this year. And that, again, I think is material to keep our eye on where we need to go. Second thing is to cogitate. There's just been a tremendous amount of knowledge shared here, all sorts of system-savvy, great evidence on what needs to be done. And we need to systematically share that and scale it so that we're not operating and recreating and reinventing wheels on our own. We run something with countries called a Joint Learning Network for UHC, which is people who are in the trenches making UHC happen every day, who agree to collaborate across countries to learn from each other and understand how they can do better. Third thing, we must anticipate change. The world is changing. We have massive demographic shifts in Africa, huge fertility, high levels of fertility, but also accelerated aging. We have change in population expectations. We have the whole awareness that preparedness for uncertainty is not a luxury, it's a necessity. And then with the things that are flying overhead without pilots, the drones, we're seeing that technology is changing the way we think. So how do we embrace change such that it is an asset for UHC rather than a barrier? Fourth is we must recognize the imperative of participating. We're multi-sectoral by definition. Education, water and sanitation, social protection, cash transfers to poor women, those are fundamental to achieving UHC, and we have to embrace them. We also have to embrace the private sector. The panel here made it clear. It isn't that there won't be a private sector. The private sector will engage in a very prominent way. But I'd also like to pay attention to the local subnational, where we're seeing in the context of democratization increasing efforts on local governance, but also the critical role of national governance and transnational governments. We saw in the context of Ebola just how important a healthy, well-financed WHO is. And so we really need to be embracing those levels of participation. Capacitate. Absolutely need to think about how governments can play a much more proactive stewardship or leadership role in facilitating and managing change towards UHC. It's not command and control. We're well beyond those old models where government does all. But they do have a fundamental role in laying out the direction, identifying that political will, and in empowering others to work in that direction. I was impressed earlier this year at a meeting where a big private sector company globally said, we've aligned our entire company strategy around the SDGs. And so it's not only government, it's other actors as well. Finally, educate. When we look to youth, when we look to the long careers that we all enjoy, we're all humbled by how much more we have to learn. And it's not only learning to be technically competent, it's learning to figure out how to express the values that are incumbent and inherent in UHC, justice, the right to health, the elimination of unfair inequalities, and also to lead change. And fundamentally, our education systems need to reflect that. So, agitate, capacitate, cogitate, anticipate, participate, educate, act now before it's too late to accelerate UHC. Thank you.
Thank you very much for that, Tim, and congratulations on time management as well. Very concise, direct, powerful words that you used there. We're mapping the way forward for Africa to realize UHC by putting people first, and you told us agitate, capacitate, anticipate, participate, Wait, I mentioned capacitate, right? And educate. I probably missed one of them. And we should act now. I'm going to silence the before it's too late. But yes, we must act that. And you talked about the role, the importance for us to define the role of national as well as transnational actors and the political will and commitment towards realizing UHC in Africa. Now I'm going to move to the last but not least panelist, Dr. Solange Hakiba. Now she's going to talk about how we can make investment in health and how that can take advantage of the increasing population of the young people of Africa. We're talking about approximately 70% of the population of Africa. We've been hearing a lot about the demographic dividend, and now you're going to talk more of the advantage that is there in terms of health returns by investing in the youth of Africa. 5 minutes, Dr. Solange.
Thank you very much. And this topic is a little bit weird in the sense that we should not sound as if we are telling the youth what to do, because this is the exact message: involve us in everything you're doing. So regardless of the commitment, the energy the youth is putting in getting involved, the first step remains to sensitize them, to educate them. And that would be formal education, that would be sensitization, that would be forums like this one where they hear about the issues that are going on. But ultimately, our goal is make them actors. Make them active enough to be able to themselves identify the gaps that are in our health system, our service delivery, our disease patterns within our communities. What are the needs? What are the shortfalls? Where can they come in and help to resolve those issues? So in sensitizing the youth, let's keep in mind, and I think Ms. Mary said it earlier again, that they are actors and not merely our beneficiaries. Then the youth today are have a great asset in their knowledge in IT and use of IT tools. Even coming up with applications, coming up with ways of connecting systems that can talk to each other. So I think this is a great opportunity and a call for them to again engage themselves into supporting their health systems to resolve the issue through IT and e-solutions. I think they've been keen on delivering so far, and I can see that there's a lot of fora where they have been engaged and requested to chip in. In that line, I would like to advocate for the youth of the delegates here, their participation into the upcoming Youth Connect meeting, the summit, that will be taking place here from the 19th to the 21st July. So this will be bringing more than 2,500 delegates, but really to look into how they can move from potential to opportunities, to action within the different fields of action or education. And I understand that Mr. Jack Ma has been invited to actually motivate the youth to go into job creation. When we talk about the youth, sometimes we are worried that they're talking about advising the minister. No, maybe the first thing would be to sensitize your family, your community. Start there, because we see that there's a great need for people to know their health status, their health opportunities, where to get service, and when to get it. And I like very much one of the programs that our First Lady, Mrs. Janet Kagame, mentioned here earlier, is the 12 Plus program. In reality, when you talk about empowering the youth, sometimes we talk a lot about what they can do with a smartphone. But when I look at Rwanda in particular, How many youth have a smartphone? How many are able to access one? So our great priority would be those who are still first young, not able to access one, or maybe not wealthy enough to buy a smartphone. So let's see what are the strategies or the activities we are implementing around those ones. The 12 Plus program is really a program that addresses the empowerment of the young girl at this point, but we can expand it to the young boy and make sure that that youngster knows exactly what's happening in their community. So the 12 Plus program, allow me to talk a little bit about it. It's basically not only empowering in reproductive health and rights, but also navigating you within your community. What does the mayor do? Who is the mayor? What can you ask the mayor? If you see littering in your community, how do you address that? If you see gender-based abuse in your community, who do you go to? If you are yourself victim of abuse, how do you voice that? If you want to promote your community into different area, how do you go for it? If you are sick, where do you go? They even navigate those young girls through the health facility, like a virtual visit, and actually they even take tours to go there and make sure that those youth not only know the theory, but can navigate within their community. So there are many possibilities of empowering them. Maybe if you allow me, a last point is, let's have our youth still on the school bench maybe, come and work with the professionals, the officers in offices, so that they link the theoretical education to the current and existing issues on the workplace. Because sometimes we request for a good resume, but guess what? They have no experience. But sometimes an internship can be experienced enough to give you a sense of the field you want to venture in and be able to work yourself into a job.
Thank you very much,
I would like to stop
Dr.
by saying,
Solange,
if you are not around the table, you may be on the menu. So make sure that you are around the table and not on the menu. Thank you very much.
Definitely. Thank you very much for that. And you talked about the iAccelerator initiative that the First Lady was talking about, and I just feel propelled to mention that in the morning we had a youth session that was organized by UNFPA in Rwanda. And this is where we met a couple of young people in Rwanda who developed those innovations for reaching out to their fellow young people and educating them about sexual reproductive health and rights. And interestingly, these young people came up with different innovations for how they can reach out to the young people in Rwanda. There were young people who do outreaches at the refugee camp that they have in Rwanda. Others developed a USSD-based platform. This is a platform that you can use if you don't have a smartphone. And interestingly, there was a group of young girls who developed comic books. And these comic books they're going to send to adolescents in different communities to educate them about SRHR. And I think it's very good that we're putting together all of these innovations to ensure that we don't leave anyone behind in empowering them about ensuring that they have comprehensive sexuality education. Now, we're going to now move to the floor and get questions from the audience members as well as comments. But there are 3 questions here that I have jotted down. And I'm going to give you all the 3 questions, and then whoever feels comfortable to tackle one of them can do so. But also our distinguished guests in the audience are also at liberty to address any of the questions. The first one is that different research on development in Africa have indicated that even in the availability and presence of support and capacity, be it technical and otherwise, without proper governance structures, without an enabling environment, there's actually a much bigger problem. So what are we doing to address the governance deficits that we have in Africa, and what could be done more to motivate political will and commitment to address the health challenges needs and priorities of Africans by our leaders. I remember somebody from the audience, and it was reflected on social media yesterday, said that in 2017, we still have some of our leaders who prefer to fly out to access better healthcare than to strengthen the in-country health system. So how do we address those gaps in governance? Second question is, I haven't heard a lot of mention throughout the sessions from yesterday around how we can ensure and support health security and delivery, particularly in humanitarian and fragile settings, and in the context, in the face of competing priorities. So it'll be interesting to hear somebody weigh in on that. And then the last one, it also came from somebody from the audience yesterday during one of the morning sessions, is on financing. We are talking about now focusing on domestic resource mobilization. And the person who posed the question actually wrote it as, are there no resources or are there better priorities in Africa? So I don't know if there's anybody in the panel who'd like to tackle one of the questions before I go to the floor to get more interventions. No? All right. All right. Sir Michael, please go ahead. Thank you very much for that, Sir Michael. More action-oriented grammar than just the nice, fancy rhetoric. Now, Mary, I can see you want to say something to one of the questions.
Yes, my response would be to domestic resource mobilization. When we begin to pursue the discussion around health insurance, the key challenge is efficient use of resources. And in many forums, we keep asking ourselves, do we have enough resources in Africa to solve our problems or not? And the answer is yes. Where are the resources is the problem, and how do we use the resources is the issue. So I think we are in agreement that we can actually generate domestic resources. For research, for fulfilling our own strategies, it's important to have domestic resources at our disposal as researchers. And secondly, how are we using the resources efficiently to fulfill our goals? So efficiency is something that we really have to go back to. Thank you.
Excellent. Thank you very much, Mary, for that. So essentially, we have only 4 countries that have met the target of the Abuja Declaration on Health Care Financing. And what you're saying is not about whether or not we have the resources, but rather we do not have the right capacities, the right kind of leadership, the right kind of institution to be able to ensure that there's efficient use of resources. Now, Tim, you want to take one of the questions?
Yes, I'd just like to build on the domestic resource mobilization. Perhaps serendipitously, just yesterday, the World Bank Group issued a publication on increasing domestic resource mobilization. And so that's giving you, I think, one focus on domestic resource mobilization, which is particularly around public sector resource mobilization. And my point here is that this is a whole of government, a whole of society issue, not just the health sector, but if the tax collection rates go from 8% to 16% to 24% through the period of the SDGs, that will do a tremendous amount to increase resources for health in the government sector in countries. So this is a very important thing to advocate for. The second point on domestic resources is the health sector is awash with inefficiency. And if we can begin to decrease those inefficiencies systematically, then we're going to get more health for the money. One example is ghost workers. Many public sectors, human resources roles are filled with people who either have died or no longer exist, have migrated, who wholly work in other parts of society, but are still on the public sector payroll. Now, we know that one can eliminate this quite quickly with modern bank transfers and better identification. And we saw, for example, in some emergencies recently, where efforts to get more workers getting an extra emergency premium were combined that the only way those workers would get paid is if they had an electronic bank account that was duly verified. And the number of emergency workers in that setting went from over 25,000 to 10,000 overnight. So I'm saying that there's lots of room for improvements efficiency as a way of making better use of scarce resources. The last point is populations don't wait for governments. The fact that out-of-pocket payments have increased as a total share of spending in this continent is directly correlated with the fact that governments are not increasing their financing for health quickly enough. Populations won't wait. They will spend, and when they spend, it's the most inefficient and inequitable way of financing healthcare. So it's the government's responsibility to provide opportunities for pooling and prepayment that can make sure then you can move to rational allocation and a much better distribution of those resources for the population's health. So I think those are critical dimensions of DRM, and this will continue to be with us as part of the Addis agenda through to 2030.
Great. Now I'll move to the floor. If we have anybody who has question, please state who you're directing the question to from the panelists, and also your country and the institution that you're representing. I already see, of course, please go ahead. Thank you very much. Please do feel free to give him a round of applause. I think somebody started. Yes. Great. And we will move to this side of the room, please. I can see 4 men with their hands up. We will take all of you, but take the nearest to you. I think to your right. To your... Sorry, could you please speak closer to the microphone?
To say that actually we have in our time a formidable opportunity, and we have the tool through through what we call One Health. And I want to say actually we have gone quite a long way in getting mind change slowly towards adopting a multi-sectoral collaboration approach when we're talking about health, being efficient in provision of health or addressing emerging health threats. And I would like maybe take this opportunity to commend WHO Afro for its leadership in promoting this One Health. They organized a ministerial conference, bringing all ministers in Dakar, and also to commend economic community, regional economic communities, ECOWAS, the EAC, for all taking bold steps in really advancing the One Health agenda. Just to appeal here to all leaders to take this quite seriously, we have here an opportunity to pool our resources. We talk about resources. It is in a situation of scarce resources that we need to put our efforts together. We cannot achieve health security in a country or in the continent if there is no surveillance in animal health, for example, in wildlife. We may go ahead and improve.
Sorry, please also summarize in 30 seconds.
Yes.
Yes.
We can go ahead and improve human health, but it is the sum of all our efforts. It is when all the sectors, the animal health, the environment health, it is when we will all be efficient, then together we can really achieve our goals.
Thank you very much. Collective efforts. I think that's a very, very important point that you're highlighting. Could you please go back to the gentleman at the back who wanted to make an intervention? Please be very concise, direct with your question.
Thank you very much. My name is Joel Mubirigi, and I'm a medical doctor, and I work for Partners Health in Rwanda. My question goes to, I would say probably Dr. Tim, but all the rest of the panel can respond, is when we think about all the definitions around universal health coverage, that looks really into providing quality health services accessible to all, but also avoiding financial hardship for people when they pay to that. To me, as a medical doctor, as a program manager, I understand clearly what is needed in terms of supply chain, in terms of human resource for health and so forth. But one area where I, at least in my mind, got difficulty to understand is how do we define financial hardship and how do we measure it? And is that definition really capturing, let's say, that farmer in the village that sells his only beloved cow for the treatment of his premature baby, or an entire family that got in debt for an orthopedic surgery? That definition captured that, and how do we measure that? Because if you want to evaluate ourselves in coming years, in 2030, that we actually remove that hardship, that financial barrier, we should have a way to define that and measure that. And
thank
to me, I don't.
Thank you very much.
Thank you
I'm
very
sure
much.
Tim has captured the question. Also, now let's move to the gentleman here. Yes, please, in the middle row. Thank you.
Thank you very much. I'm Sam from Global Fund. Thank you very much for the great presentation. I really echo that Tim said. Actually, value for money is very critical. And we are supporting together with the World Bank and WHO for allocative efficiency. And we could find a very good saving in a country. So especially the national strategic plan, that is very critical. Many countries still have a wish list, but we need to look at the better planning for the good allocative efficiency and the technical efficiency. And we also need to support the national health accounts, because many countries we cannot track that real expenditure. So this is also the real, wiser and smarter planning is very critical. Other time also we need real participation of civil societies, private sectors, etc., even from planning, so that we can have a better implementation.
Thank you very much. Can you please move to this side of the room? I can see a gentleman right next to you. I can see that there isn't a gender balance in the interventions, but I know that as women, we're still warming up for when we make our interventions. So please go ahead.
Excuse my voice, I catch cold. Last 2 days, we heard a lot about the problems and pressing needs of this continent. With so many honorable ministers and respected directors of different institutes, I was actually hoping to know a little bit more about the solutions. Honestly, most of these problems existed 30 years back, 60 years back. And in 2017, we're still talking about those problems. Still, there are diseases exclusively present in this continent, and vaccines are made in CDC. Drugs are developed in an NIH-funded lab in Trumpland. So my question to the panelists would be, when should we expect to see African problems are solved by the innovations and inventions made in Africa by the Africans for the African people? Will that day ever come in our lifetime?
Thank you very much. I'm going to take the last two interventions, and I am going to be biased towards the ladies. So if there is a woman with a hand up, please go straight to her and give her the microphone. Okay, maybe another time. All right, the gentleman with the pink shirt and the red tie, is it maroon tie?
Thank you.
In just under a minute, straight to the question.
Okay, thank you. My name is Mwananawe Imam. I'm National Coordinator of IMRO, and I work also with the Civil Society Organization Forum at the East African level. My intervention is just to add my voice to the Dr. Michael, how we can involve civil society organization and make sure that the approach of multisectoriality is well captured. Secondly, the role of civil society is crucial. When you look at advocacy activity interventions, accountability interventions, outreach, implementation interventions, so we can't ignore the role of civil society to make sure that the road to universal health coverage in Africa is achieved. Thank you very much.
Thank you very much. And then the last intervention, I believe, is from Dr. Patrick. Dr. Patrick. Dr. Patrick is not in the room?
I thank you very much, and I thank all the panelists. Tim, it's a pity that the reforms we began in 2000 and we didn't build on them. But first I want to make the point that the definition of universal health coverage that was put up then was quite broad and embracing, and probably should be taken forward, as some people have now suggested here. Universal health coverage is a means to an end. It is not an end in itself. The discussion as if it is an epidemiologic entity of coverage, I think is distortionary, and therefore we need to get granularity, as you yourself have said before, on what the components are, so that we focus public-private partnerships for a public purpose, as somebody has mentioned here, for a clear benefit. Gavi is a very good model, a very well thought out problem and a solution that is being solved through a partnership that is extending an intervention to save lives.
Dr. Patrick, you have 20 seconds to wrap up, please.
And therefore, I would encourage that we build on this. Secondly, what interventions are you making in the bank and development banks to fund civil society organizations to engage in universal health coverage, focusing particularly on the two elements that are now not being, one, the fair financing, and two, social safety nets.
Thank you very
and
much,
lastly,
Doctor.
reframing the sexual and reproductive health and rights for adolescents and the youth to focus on parents, not on the youth. The problem is with the
Doctor,
parents.
thank you very much.
And we need to reframe this. I thank you very much.
Intervention there. Thank you very much. Very passionate indeed, and I appreciate that. Now I'm going to go back to the panel, and we have about 6 minutes left to wrap up everything. I believe most of the questions were for Tim as well as Sir Michael. So I'm going to start with you, Tim, in just 2 minutes to address the questions, and then I'll move to Sir Michael to address the questions that were directed to you, particularly on capacity building for civil society organizations and citizen-led accountability. And then after that, I'll give the other members just remember, I had said earlier on, you're going to put together one word. You're going to give one word that summarizes your experience of the first ever Africa Health Forum. So after Tim and Sir Michael, we're going to have the one words from the other panelists.
So very quickly, the definition of financial hardship does include the example that you provided through something called an indicator of impoverishing expenditure, which is expenditure for health which causes you to fall below a threshold for poverty that's defined. And so there is a very clear definition in that, and that's in part to get to the point that Patrick Kadama was making, is why WHO and the World Bank have agreed on explicit indicators to monitor progress towards UHC. If you go back and read those documents, they'll not only put you to sleep, they might also give you some details on the technical basis for that. And I mentioned this with respect to coverage. Coverage is an intermediate indicator. It's not an impact indicator. But the coverage indicator that we have is a composite of 4 core domains of the spectrum of promotion, prevention, and treatment. And it also includes, Michael, you'll be glad to know, interventions that are not primarily done either to individuals or within the health sector. So it's a start. It can be improved, but it is measurable. And I think that context of progressive realization is very fundamental across all settings. The country that I come from, Canada, we're only 60, or less than 60, we're 55 years into our system of UHC, and we still are far from achieving those objectives of effective coverage and financial protection. We've made progress, but there's still a ways to go, as there is in the UK NHS. The final point that I would make is on this issue of Africa's creating their own solutions and being in charge of their healthcare systems. I don't think we have to wait. I think it's happening. I've been so impressed by the innovations that are taking place all over the place. I mentioned 2 yesterday in my talk, the MTIBA program. There's no other country that has... My point is that if you look forward to 2100, 4 billion people will populate this continent. This is going to be the center of the world on that basis, and I think on that front, there's just an infinity of opportunity, not only for health, but all other dimensions with respect to the well-being of this continent. So I think it's a very exciting future.
Thank you very much, Timothy, for that. A round of applause for him, please. And now, Sir Michael, the questions that were addressed to you in just under 2 minutes, please.
2 questions. One, the implied
is that our knowledge is improving all the time, and a lot of the knowledge that we need is how to get things done. We know lots of important things that are important for people's health, but a lot of the knowledge, and we need to be self-questioning about what we do, because we do a lot of wasteful things and some harmful things, so we need to be self-questioning. Now, the best, let me violate what I said before about learning from next door. The best example of the civil society organization that I know is the Self-Employed Women's Association, which began in Gujarat in India. And why I think it's a model is because it's a membership organization of the poorest, most marginalized women in India. And they support each other. They have educated people who are facilitators, have good ideas about how to get things done. But they look at the needs of their sisters and they say, how do we meet those needs? When they ran into problems with the government, I said, what did you do? They said, we solved it in a safer way. I said, what did you do? Our sisters went on a march to the Gandhi ashram. There's no way any government in the world was going to dominate that. The government backed down and the women won. So I think of empowerment both as a goal, but as a process. And to anticipate your question you're going to ask the others about the one word that's important, I've been thinking that the opposite to poverty is not wealth, it's justice.
Thank you very much, and may I please arrest your statement at that point. I think you ended it very well. Please give him a round of applause. It is not wealth, it is indeed justice. Now, thank you very much. We've come to the end of this last closing session, but before we finish, I've asked each of the panel members to give one word that summarizes the experience or what they take away from this 2-day first ever Africa Health Forum. So I'm going to say your name and please one word, and if you do start a statement, I will have to stop you. I'm going to start with Sir Michael. One word.
Empowerment.
Dr. Solange.
Responsibility.
Mary.
Life cycle.
Dr. Bennis. Capacitate, that's a word. And last but not least, Timothy.
Leadership.
Thank you very much for that. Now, wonderful, absolutely. And my word would definitely be action, because I strongly believe that in Africa, where a woman does not lose her life while giving birth, where adolescents have more choice than chance, and we ensure that every young person does not only survive childbirth, but they're able to thrive, transform, and realize their full potential is very possible. What we need to do is move away from just promise and potential to more progress, delivery, and actions. And on that note, I'd like to thank the director, Dr. Mweti, and a special thanks to Dr. Prosper and Dr. Simplis, who have been working very hard to put together these last 2 sessions for the Africa Health Forum. Asanteni sana, merci beaucoup, thank you.
Thank you very much, Ms. Guguhle Jean Paladi. I think we owe her another round of applause for the excellent moderation for our last 2 sessions. Thank you. We have just come to the end of session 6, and for now we have a 30-minute health break, and I will invite all of you to come back into the room at 5 o'clock for the closing ceremony. Thank you very much.